So Deb Cavel Greant has had a 50-year career as a journalist, working for newspapers, magazines, health and environmental publications. She has co-authored an environmental textbook for the British Columbia in Canada high school curriculum, and wrote a book on the neuromuscular disorder myasthenia gravis, which is now in its 3rd edition. Deb's family history of hypokalemic periodic paralysis is traceable to her great-great-grandfather, who died at the age of 32 during a paralytic attack. She has numerous affected family members, including her father and all 3 of her siblings.
Jake is saying, so...
Oh, she can't hear what I'm saying. Okay, anyway, Deb was misdiagnosed with a succession of disorders until she was finally diagnosed with hypo.
I hope he's finished.
PPA at age 41. So her diagnostic journey made her acutely aware of how important it is to educate both physicians and patients. She's one of the directors of the Periodic Paralysis International, based in Calgary, Canada.
Thank you.
There we go.
Good afternoon. I hope you're hearing this. If you're not, you can call me back. I'm pleased to be with you. I've been enjoying what I'm hearing. Pleased to be here even as a disembodied voice. I'd like to be with you in person, but many of you are old and dear friends. I would love to see you, but my body does not like traveling any further than the grocery store these days. Last October, Dr. Franklin McCord and Karen Newcott-Roth and I co-authored a paper on how permanent muscle weakness affects the quality of life in periodic paralysis patients over 40. This talk is drawn from the information in that paper and addresses how we can use that information to show or reduce the impact of permanent muscle weakness. What is permanent muscle weakness? Muscle power, the combination of force and speed, is probably the most reliable indicator of physical function in humans. In periodic paralysis, muscle power gradually diminishes as muscle is slowly replaced by fibrous tissue and fat, leading to weakness, which is all present and does not vary in intensity from day to day. During attacks, fluid and sodium move into the muscle and form tiny bubbles, as you can see there. When the attack ends, the fluid and sodium move back out of the muscle into the blood. They leave behind a little vacuole or empty space. When you're young, these vacuoles heal up quickly, but as you age, the healing process slows in your muscles like everywhere else. Instead of healing, the vacuoles fill with fat, and fibrous tissue forms where the groups of vacuoles coalesce. Over time, more and more muscle tissue is replaced by fat and scarring. The tipping point when this process begins to have a noticeable effect usually occurs in the patient's 40s to 50s. So from November 2011 to January 2012, all HypoPP listserv members over 40 who met rigorous diagnostic criteria were invited to participate in a 68-question survey about muscle weakness. There were 66 participants, 20 males and 46 females. See the ages here. And here you see the forms of periodic paralysis that our respondents had. And the hypokalemic, the myopathic form, which they didn't have paralytic attacks, but developed myopathy as they were older. And here you see the ones who had identified mutations, which kind they had, and as is common, most of the hypo had R528H, there was some R123 and 9H, and on as you see. Most, 62%, had family history of periodic paralysis. 24% were unsure if they had a family history or not, and 14% had no family history that they could find. The symptoms began in 74% in childhood or puberty, so most people had onset by the age of 20. There was an average, though, of 26 years between the age of onset and the age at diagnosis, indicating that physician awareness and diagnostic methods need improvement, as Dr. Siegel has pointed out. Magic 40th birthday. According to some physicians and literature, age 40 is when the cure kicks in. But some physicians use this as a rationale to not treat. They say, well, you're 40 years old, you're 35, the attacks are going to stop in 5 years, so there's no point in giving you any medication. But there's no 40th birthday cure. Paralytic episodes stop in a very few people while they're in their 40s, but abortive attacks and permanent muscle weakness usually follow within a few years. Abortive attacks, the term abortive attack was defined by Dr. Links in the 90s. They're periods of reduced strength which fluctuates over days to months, but never progress to a paralytic attack. Most patients say abortive attacks are more disabling than the paralytic ones, which are over and done with in a matter of hours. Abortive attacks can last so long, they're mistaken for permanent weakness. And we even see reports in the literature that a patient who's never been treated, who's 50 years old, has been given diamoxin, their permanent weakness has been cured. But that wasn't permanent weakness, that was an abortive attack. The two are not differentiated in the literature. An abortive attack can be treated and it can get better. Permanent muscle weakness does not change in day to day. Surprisingly, the patients that we had reported that they still had episodes of weakness or paralysis, daily to weekly. In over 70% of those, they did not decrease in frequency or severity with age. As you can see here, many still had episodes every day, and they were not any less severe in over half of the patients. We ask, do you have permanent muscle weakness, which is always present and varies little from day to day? And 68% average said yes. We were the first to report that permanent muscle weakness affects the proximal muscles more severely than the distal ones, and the quadriceps most of all. This slide shows which muscle groups were reported as being weak. And you can see that at the bottom of the list here, the quadriceps were weak in 82% of our patients. Those are the big muscles in your legs that help you stand up, help you lift your legs, help you walk. % of our patients reported pain, 89% reported fatigue, 67% reported muscle stiffness. These four factors, weakness, pain, fatigue, and stiffness, have a significant impact on quality of life and are risk factors for social isolation, immobility, and depression. Patients need to take control and use some of the steps that Grace discussed to reduce their pain and help ensure that they maintain activity and balance and a positive attitude over their lifespan, because it makes a big difference. People get very, very disheartened when they are weak, day after day after day, and a positive attitude really does make a big difference. Because here's what we're looking at. Between 18 and 35, 83% of these patients said they were very active to moderately active. At the time of survey, look at this, it's totally flipped. Only 14% were active and 86% were sedentary or only mildly active. This is a huge difference. 92% reported that they had reduced strength and stamina. 89% had difficulty performing the activities of daily life. 75% had trouble doing even mild exercise. 42% had trouble climbing a single flight of stairs. 25% were unable to walk more than a few steps without help. And not surprisingly, 91% were dissatisfied with what they were able to accomplish in a day. Here you see the quadriceps muscles that are affected. And you can see why those big muscles and weakness in those big muscles would make a huge difference. You can't stand up from your chair alone anymore. It's hard to get in and out of the bath. Climbing stairs, doing almost anything requires the use of those big muscles. I have gotten a couple of these reversed. Okay, we found that falling was a significant danger to people. If 67% of our patients had fallen and injured themselves badly enough to need medical attention afterwards. Injuries included bruises, sprains, torn ligaments, and joint capsules, injuries of cartilage, bone fractures, concussion, skull fractures, and internal bleeding. In addition to this, there were patients who did not participate in the survey because they had died after falling. I know at least 2 who died of subsequent falls. This severe incapacitation and the high rate of injuries caused by falling have not been given sufficient attention in the medical literature. This is not a nuisance disease. Our analysis suggests that decline in activity is not due just to weakness and a lack of endurance, but also to a real fear of falling or provoking an episode, especially when you're outside home. Patients reported weakness or paralytic episodes being mistaken for drunkenness or seizures and were fearful of being taken to the ER. 17% of our respondents used a walker, 20% used a scooter, 23% used a wheelchair, 29% used a cane, 26% used other aids. All right, I'm going to go back up. Now, we have our patients took a range of medications. Most of these we all know about. And it's vital to have an aggressive enough medication regime to prevent weakness as much as possible. If the commonly used meds don't work, do some research, seek advice on the different lists, and ask about the medications that are being used successfully by other people. Some doctors are a little more adventurous and will prescribe something for a patient based on their own experience or what they think might work, and it might work. So don't accept that nothing more can be done until you have tried everything that's possible. We found that these are some of the drugs that people were using that were successful for them, that are not used, that are not used, that are not used, that are not used.
Perfect. Okay.
Oops. Wait a minute.
Yeah, we're good now. Can you hear me? Oh, can you hear me?
Now.
Yes, good. I'm going to make a phone call.
Thank you. Bye-bye. Doing this one way is rather difficult. I said doing this one way is rather difficult. Okay, so our possible alternatives if you have hypo: baclofen, gabapentin, methacillimide, and 3,4-diamine pyridine. For hyper, tegretol, Florinef, avapro, and methacillimide. For paramyotonia congenita, Paxil. This is an antidepressant called paroxetine, used in a small dose, 10 to 20 milligrams a day. ATS, triamterene. Okay, as a group, we seem to be more sensitive than other people to other medications. And as we get older, we sometimes need other medications. But one in particular I'm going to mention are statins, which are given to lower cholesterol. Now, these can cause muscle destruction in patients, healthy patients, but they cause muscle destruction in patients with a variant in either of two genes. In the company 23andMe, testing company, which they test for response to about, 60 commonly prescribed drugs. They test several that are important to PP patients, but I'm going to only mention the statins. So they're given to patients to lower the cholesterol and prevent second heart attacks. Unfortunately, they cause serious side effects, including muscle breakdown, myopathy, kidney failure. Layered on top of the muscle myopathy already present in a patient with periodic paralysis, statins can cause irreversible muscle destruction in a matter of days to weeks. So there are two specific variations that increase the chances of you having myopathy if you take a statin anywhere from 4 to 17 times. And they test for these variations. And you can get the test from 23andMe, see the URL for their company. They test for $99 plus shipping, U.S. funds. If they didn't test for anything else, it would be worthwhile to take that test for that one thing. As Grace has already pointed out, it's absolutely vital to eat a nutritionally adequate diet. Each of the types has its own specific kind of diet. So these are all listed. We have very detailed diets on the HKPP website. Now I'm all puzzled. It doesn't just make a difference that day, but the diet that you eat at 35 makes a difference in what your muscle strength is going to be at 65 and 70. So you do need to eat a decent diet and to supplement as needed with creatine, vitamin D, omega-3 fish oils, whatever it is that does you good. We questioned our participants about physiotherapy and self-directed programs of exercise. We found that in both cases they did about the same kinds of exercise, but 49% gained some benefit from professional physiotherapy, but 40% deteriorated. 83% followed self-directed programs of exercise, and 62% gained benefit, and 16% deteriorated. The comments they made was that physiotherapy tended to overestimate what they were able to do, and the intensity, frequency, and duration of the sessions were too demanding and would set back. They could keep up to begin with, but they would go soon, they would start to lose ground. Emotional mobility is often a signal that your serum K is changing. It's going up or down depending on what type you have. So when you find yourself getting suddenly teary or irritable, or cranky, or hostile, stop and think, maybe I need some potassium. Your family may point out, go take some potassium, or whatever it is. Go take a spoonful of cornstarch, whichever it is that you use to manage your potassium on a very short term. 35% of women in the study and 33% men reported depression. This can be treated, and it should be. Some of the antidepressants cause increased weakness in some patients, but if you try one and it causes increased weakness, try the next one. And if that makes you weak, try the next one. But try several different ones, because one is going to work for you in the end. You may just have to try several until you find one that works. So our results suggest that most patients are going to develop permanent muscle weakness to some degree by the time they're in their 70s. And it has a greater impact on the quality of life than patients previously recognized. However, we cannot afford to lie around and ask, what do I do? We need to remain appropriately active to maintain strength and balance, like yoga and meditation to reduce stress. We need to educate our physicians so we have access to aggressive enough medication to reduce weakness to the absolute minimum. Avoid our triggers. Treat depression if it occurs. Carry our medical information with us at all times. I can't tell you how many 2 to 8 phone calls I've had from the ER after someone has fallen and needs emergency surgery and they do not have their medical information printed out with them. Print it off. The forms are on the PPA site and the PPI site. Print it, carry it in your wallet, and put it in your car and around your neck, wherever. But make sure you have it so it's there when it's needed, and you don't end up getting something you shouldn't have in case of an emergency if you can't speak for yourself. And you have to learn to advocate for yourself. If the doctor says, well, I don't think that maybe that medicine would do you a whole lot of good, you have to say, well, you know, it might not. You may be right. But can I try it and see? And if it doesn't do me any good, I can quit it. So you have to advocate for yourself. As patients, it's our responsibility to do all we can to prevent permanent muscle weakness and postpone its development as long as possible in order to lead satisfying lives for ourselves. Thank you. This paper was based on this talk. Okay. You can find the paper this talk was based on, available for download in a PDF format from a link on the front page of our website at www.hkpp.org. Thank you.
So I want to allow the audience to take some questions, but I just want to just give a personal anecdote that Deb has been kind of hero and mentor of mine all throughout my periodic paralysis career and my medical student and doctor career, because she's done so much for everybody. And so yeah, just thank you, Deb, for being there all the time.
It's been a pleasure.
Okay, so questions. There's no questions? I don't believe it.
Nobody has questions.
It's at the end of the day. It's a really long day. We have one here. Okay.
Hi, this is Kelly Bosarge. I wanted to talk about the permanent muscle weakness for a second. I am 35, and at 34, I was pretty much told that I had permanent muscle weakness by the MPA clinic and the doctors that are treating me in Jackson, Mississippi. Last time I was in the hospital, they were able to bring my potassium back up to from the 3s to the low 5s, and I did not recover. So would that be considered a confirmation that I'm permanently weak? I didn't recover. I used to recover, and now I don't. So would you consider that a confirmation of that this weakness is most likely permanent, or at least some of it?
Are you able to keep your potassium there?
No, ma'am. No, ma'am.
So
It's not staying there.
There's the crux. It takes, if you've had a big attack, it takes time for those vasculature to heal. Even in younger, they'll they heal fast, but then they'll heal in a day or two, and it really doesn't make that much difference. But it takes, the older you get, the longer it takes to heal after you've had an attack. It takes time for vascular. When they bring your potassium up to 5 for, like a half an hour or a day, but you have to keep it up. It doesn't get the medication in you enough to stop that process of sodium and fluid moving into your muscles. You've got to get the fluid power your muscle. And that may take a combination of therapies. It can take insulin and potassium and diamoxy response. Diamox or methamphetamine or, usually by that point, you have to take some kind of combination therapy. You can't just take potassium and you've got to do something, take something to keep the sodium and the fluid that's constantly moving across that membrane. Keep it out and so that you don't have that buildup of edema. But at 35, you really, unless you've been down for ages, you shouldn't have enough muscle weakness so that you can't do much. I mean, you may have some, but I was astonished when I first got diagnosed. I was 42, and I was having to climb the 5 stairs to our second-story bedroom and come down on my bum like a baby. I got dialogues and I was able to walk up and down the stairs with no problem.
I am on, just to let you know, I'm on potassium, I'm on Diamox, I'm on Inspro, I'm on Amiloride, and my condition has improved slightly to the point that I'm not waking up paralyzed every day anymore like I used to. But this has been going on for years, and just getting somebody to believe me and actually take me seriously took a long time. But I've been exercise intolerant for years now, and at this point they believe that it's permanent, and so I am on all of those things, and my potassium is usually in the low to mid 4s now, and it used to stay in the 3s. So there's been a slight improvement, but it doesn't go beyond, 4.3, 4.4, something like that. And I'm on a walker, just so you know. I've been doing pretty badly here the last few years. So I was just wanting to know.
You're on Diamox, you say?
I'm on Diamox, I'm on potassium, I'm on Inspro, and Amiloride.
That's going to be the go-to for substitute for Darren. I know that the Diamox ran out for me and it just wasn't working. And more and more people are losing methamphetamine because it's a very, very close cousin. It's actually a little more potent than Darren. And you might try and talk to your doctor about doing that trial. But start small because it is a real problem. I tried to go straight from 200 milligrams of Darren to 200 of methamphetamine, and I ended up constantly so good. So I did to 100, and like that did it the same. But the methamphetamine is really, really close. It's not exactly the same. It doesn't work for some people. It doesn't work as well. Some people it works better. So you just, that would be like my advice. So go and talk to your doctor about it. Let's try it. It's called dexamethasone.
Okay. I will ask him about that. I was just wondering if they bring it up and it's up for, does it need to stay up for days, weeks, months? I mean, obviously, I know the goal is to keep potassium up for those of us who have hypo. So I guess the goal is to try to get it up there, keep it up there, and give the muscles time to recover. Am I understanding that?
Yeah, well, Dr. Lansford is fine.
I'm sorry, Deb, we're having webinar issues for a second.